I am pleased to welcome Elizabeth Mitchell, President and CEO of the Purchaser Business Group on Health, to How Would You Fix It? PBGH represents large employers and other institutional buyers of healthcare from both the public and private sectors. Elizabeth Mitchell, thanks for joining us.
So glad to be here. Lot to fix.
Yeah, a lot to fix. So I want to start by having you talk a little bit about employers' role in the U.S. healthcare system, how it started and why it persists.
Yeah, well, I think we know it was an accident of history, right? They weren't looking to get into the healthcare business, but when, they were looking for alternatives to wages, when there were limits on what they could offer, and they started with, what was a pretty inexpensive offering, helping pay for hospital care. And that has now grown to be the second largest line item in their budgets after payroll. So it has taken on a life of its own, huge economic impact to companies, impacts on wages. But self-insured employers that I work with are committed to achieving affordability, equality, and access on behalf of their workforce. It is strategic for them. Healthy employees are, what they are aiming for, but they also have the incentives, right? They have the aligned incentives with their employees and their families of lower costs, better value. So they employers cover over 160 million Americans. So they are a major player in healthcare in the US, for better or worse, but they are committed to achieving um, just a better system because they're paying for it and because their employees need it.
What's unique about large employers, particularly the large employers that you represent, not only the ones that not only pay for their workers' health benefits, but also design and manage them in most cases?
Yeah, it's a great question. I work with large and jumbo self-insured employers and public purchasers like CalPERS. Um, a lot
CalPERS, for those who don't know, is the California public pension system. So it's
Yeah.
the University of California system and lots of other big public employers in California, right?
Yeah, they are the second largest purchaser after Medicare, I believe. So not small. And I mean, honestly, the major difference for large employers is the leverage, right? Volume brings leverage in negotiations. Um, but they also often have, you know, sophisticated benefits teams. In many cases, and more and more often, they have sophisticated sort of data analysts and teams who are really seeking to understand um, what is driving costs and what they can do differently. And they have the ability to negotiate arrangements that small employers just don't have. Most small employers are fully insured, so they're really just at the mercy of the health plans. Um, there is somewhat of a myth that the health plans are responsive to large employers. That is sadly not often the case. So there is, I would say one of the things that our members are looking to do is sort of aggregate their purchasing power even across large employers. Because, when you think about it, Costco gets better rates than an individual because, of their buying power. As large employers have sought to exercise that leverage, the system has consolidated in response. So the health insurers have consolidated, the health systems have consolidated. So there's been this arms race of consolidation, meaning that even the largest employers in the world are smaller and don't have the leverage many times. So they're looking at how can they align or aggregate even across large employers to really drive the changes they're looking for.
And I really feel like large employers in particular have been active in this whole, quality debate in a way that sometimes people don't realize how much of a role they've played in trying to beef up quality. But as you said at the beginning, it's their incentive that the care
Absolutely.
be, not just effective, high quality, and cost effective.
Yeah. I mean, I think I'm quoting Leapfrog, but our members are absolutely clear that there is no good price for low quality care, right? They don't want to be paying for bad care and putting their employees at risk. So they are absolutely committed to quality. And better care costs less. If you aren't readmitted, if you don't get an infection, if you don't have to bounce around the healthcare system, having more and more procedures and tests, it's lower cost, better patient experience, and better outcomes. So our members are really focused on what are those high quality initiatives with high quality provider partners that reduce the total cost of care, even if they are higher priced. They know that value is actually when you have quality and fair cost.
And Leapfrog, of course, for those who don't know, is actually an employer sort of launched quality project, right?
We were part of that launch. PBGH was long ago.
Yeah. So the Leapfrog keeps track of of quality initiatives and tries to push them along. Well, the premise of this entire project is that we're heading towards another major national debate over health because just about every stakeholder is unhappy with the status quo. I assume that's at least as true for large employers now as it was in the early 2000s when the ground was being laid for the Affordable Care Act. Do you agree with that? And just how dissatisfied are your members with the current functioning of the healthcare system?
I do not know any employers that are happy with the current system. I will say that dissatisfaction is growing exponentially. Every year of double-digit price increases and lack of access and just administrative complexity. It would be hard to overstate the frustration levels. One of our members joined us on a Hill visit a few months ago and said literally 2 years ago, they never would have come to advocate to Congress for change because they just manage their health benefits. But things have gotten so bad that they are now, front and center saying these are the policy changes we need. We're going to take our partners out to bid who we haven't, done that in years. We are seeing readiness for wholesale changes that I've never seen before. So there is very high frustration, but I also see that as a big opportunity.
So, how would your members fix the system? What are some of those policy changes that they would like to see?
Love that question. So there is no simple answer. I know that goes without saying, but there's a collection of changes that we are prioritizing based on evidence. There's not that many things that have the evidence that they reduce costs and improve health, right? So one of them is primary care, really robust primary care, and not the kind that is just set up as a feeder into the health system. It manages health, it does all the preventive work, includes behavioral health, and refers patients based on quality and appropriateness. So an advanced primary care strategy, a foundation of a system, is a top priority for our members. So there's one. That includes one of the other major strategies that works, which is referring only to the top quality specialists. There is huge variation in provider performance. There just is. Happy for everyone to get better, but in the meantime, our members want to go to the best providers. So top quality specialist, robust advanced primary care, those are two things. Another really is more on the purchasing side, right? There is so much administrative waste in the system. And, some of our members now are turning to AI just to look at their contracts and realize that they are paying these absurd fees they never agreed to. And there are anti-competitive contracting practices that are alive and well that are absolutely driving up costs. And not to go back to the Sutter case, but the injunctive relief of the Sutter case actually got at a lot of that. And
And Sutter, for those for the shorthand, is the large California hospital chain that was sued over anti-competitive practices. Is that right?
yep, that is it. And I will say, it was an out-of-court settlement, but they did reimburse the employers and purchasers over $500 million. So there were clearly some savings to be had. And but Sutter is just one of many. I mean, these are common practices in the industry. Uh, it, but all or nothing, steerage or even prohibiting steerage based on quality. There are contracts that prohibit employers from even doing direct contracts or any of the innovations that they want to pursue. I mean, it's like your credit card company saying you can't buy any of these things, even though it's your money, right?
Or
You're
you
paying
can't
the
pay with
bill.
the check.
You can't pay with a check. You can't do anything. We will tell you what you can do. And we're starting to see some really bold moves by members like 32BJ that just did this enormous direct contract. And they had to go to the mat to get permission to do that. Think about like needing permission to spend your money on, behalf of your employees, the way that you know it should be spent. So there's a lot of movement in terms of just more assertive contracting and making sure that there's flexibility and ability to steer towards the highest value partners that employers choose. So, and then finally, I know that was a lot of items, but transparency. It is absolutely essential. It is necessary but insufficient. We know you've got to use the data, but we just did an, fairly significant demonstration project with 5 of our large employer members using the new price transparency data. And there are immediate savings opportunities just by looking at the data and realizing you can get the exact same quality or better quality service across the street for a fraction of the price. And that has immediate savings for out-of-pocket costs as well. So using transparent information to find the best partners, banning anti-competitive practices, and investing in primary care and high-quality specialty care. Those are my top few.
There are voices both on the left and now on the right who would like to get rid of the basically employer-based system that we have.
Yeah.
Medicare for all, and would take that away. Basically would have the government, if not providing, then at least paying for all healthcare services. Now we're seeing Republicans talking about, big bad insurance companies, and we should just give people money and they should buy their own care. Where are large employers on that sort of? I assume they would like to keep some semblance of the system that we have now in a reform system, or am I wrong? Are they ready to give it up and let everybody fight it out for who provides health care?
Well, I represent, a subset of jumbo employers who are very progressive, very innovative, and very invested in, fixing the system. That said, I don't think anybody would say it's working right now. We have a very real affordability crisis. And I would say jumbo self-insured employers are some of the best positioned actors to do something about that. They have the opposite incentives. They want lower cost and better quality. So if they are empowered and enabled, in some cases through policy change, to be more effective purchasers, I do think that that is a viable strategy still. Because, even if you just gave everyone, cash, you still have a price problem. It just becomes the problem of the patient instead of the purchaser, because prices are the issue here. And consolidated, unresponsive, providers and plans, there is a tendency, and it's not totally unjustified, of, blaming the customer. But there are some uh, aspects of our system that need to change, whether the government's paying for it, individuals are paying for it, or employers are paying for it. So it's a matter of um, how do we get at that? If it was Medicare for all, they set prices. Maybe that will work. I think the opponents of that historically have been hospitals and health insurers, not employers. But employers are committed to playing a very active role in achieving affordable, high value care.
Well, that was sort of my question. Are employers ready to say, we would like to wash our hands of this and let somebody else do it? Or would they prefer to stay involved? Or I guess I'm sure it depends on the details, but
It depends. I mean, again, we don't work very much with small and mid-sized employers, but
I'll
um,
talk to them separately.
yeah, it wouldn't surprise me if they wanted to wash their hands of it because they have so little leverage. I think that there are large employers who remain committed to this. But, depending on the policy environment that we are in the next 3 to 5 years, who knows? I do think that if employer-sponsored insurance doesn't demonstrate real affordability in the next few years, I think it's an open question.
So we seem as a society to be growing further apart rather than closer together on a lot of policy issues, not just healthcare, but education, climate, immigration. How do we get back to a place where people who disagree can work together to do something, to address something that everybody agrees is a problem, like the state of our healthcare system? I realize that's sort of beyond your pay grade, but
It
unless
definitely
people
is.
think about it, we're not going to get there.
No, I think it's a really, really important question. I don't necessarily have the answer, but I mean, I think it's also finding where we have agreement, right? Everyone, well, all the people I work with think we are paying too much for healthcare. So we've got to have a clear goal of affordability. And like employers alone can't fix that, right? So how do they partner with clinicians and providers and communities and governments to actually achieve that? I think if you focus on those sort of pragmatic shared goals, I mean, it may lower the temperature a bit. Healthcare is also so complex. Everybody sees different sides of the elephant, and they have, very strong views. They're not wrong. It's just not the whole system. So really taking a systems approach, understanding the existing practices and incentives and behaviors. I think level setting on why we are where we are is also really important. And I do not believe it is well understood. I talk to Congress a lot and staff and agencies and administration and you know there's a pretty deep understanding of Medicaid and Medicare, but not the commercial market. A lot of people are surprised when, a large employer asks for their data and they can't get it. They're like, "What do you mean? You're the customer." Exactly. But that's not how the market is working right now. So really understanding the actual barriers, I think would go a long way to sort of, you know, at least some initial consensus.
So more education, basically.
Education and alignment on large goals, even if we have some differences on, how we get there. And, respecting that there are going to be different strategies. I'm in Maine right now, and rural Maine may need a whole different approach to paying for rural behavioral health than you would have needed in San Francisco. So let's be open to multiple approaches to the same problems. One of the things that is changing right now for self-insured employers is really a result of the Consolidated Appropriation Acts of 2021 and 2026. So there is significantly more scrutiny on fiduciary practices of self-insured employers. They are tasked and charged with being stewards of the resources on behalf of their employees, and they are being held to a much higher standard for that. And I think that's appropriate. The challenge, however, is that fiduciary obligation does not flow through to the vendors that they have traditionally relied on.
The
So
healthcare providers, in other words,
the
and the insurance
healthcare
companies.
providers, the insurance companies, the PBMs, all of the middle people, they don't have those obligations or incentives. And so you're starting to see new dynamics emerge between the employers paying for care and those vendors and intermediaries. And it's getting tense sometimes. And then the other piece of that of the Consolidated Appropriation Act's changes are disclosure requirements. So consultants and brokers are now required, just as an example, are required to disclose how they might be paid or what financial relationships they may have with health plans or PBMs that were not visible before. So there has been a real reliance on these advisors and on health plans, frankly, and PBMs by employers that are now being questioned. They're being questioned because they have a fiduciary obligation to sort of verify that they are paying fair prices. Um, but also because these disclosures are just bringing to light things that weren't clear before.
Why
So
they were required, I assume.
exactly. I think they are very healthy changes in the market. The market is still catching up, but it is forcing employers in a healthy way to bring more of this in-house, right? You cannot outsource that risk. You can't say, well, my health plan told me this was a good idea. That doesn't fly anymore. They are being held to an expert standard. And I'm seeing more and more of our members really build the infrastructure to look at the data, look at the contracts, revisit their arrangements. And I think that's really important. So that new fiduciary pressure combined with the affordability crisis, I think is going to be a catalyst for meaningful change.
We will see. Elizabeth Mitchell, thank you so much.
Thank you.